Welcome to your focused review of the gastrointestinal system. This is a core area of knowledge for any family nurse practitioner. You will encounter GI complaints daily in your primary care practice. Understanding the fundamentals is not just about passing your certification exam, it is about providing competent and safe care to your future patients. The GI system is a long and complex pathway. It begins at the mouth and ends at the anus. Its primary functions are digestion, absorption of nutrients, and elimination of waste. Think of it as the body's sophisticated processing plant, where every component has a specific and vital role to play in maintaining our overall health and wellness. To master this system, we must first appreciate its anatomy. The main organs include the esophagus, stomach, small intestine, and large intestine. The esophagus is the muscular tube connecting the throat to the stomach. The stomach is a J-shaped organ that uses acid and enzymes to break down food. Next, the small intestine, comprising the duodenum, jejunum, and ileum, is where the majority of nutrient absorption takes place. Finally, the large intestine, or colon, absorbs water and electrolytes from the remaining indigestible food matter and then passes useless waste material from the body. These organs work in a coordinated sequence to process everything we consume. We must also consider the accessory organs of digestion. These are the liver, gallbladder, and pancreas. They are not part of the main tract, but they produce or store substances essential for digestion. The liver has many functions, but for the GI system, its most important role is producing bile, which helps emulsify fats. The gallbladder is a small organ that stores and concentrates this bile. The pancreas produces powerful digestive enzymes that break down carbohydrates, proteins, and fats. It also produces bicarbonate to neutralize stomach acid as it enters the small intestine. Problems with any of these accessory organs can cause significant GI distress and systemic illness. Understanding this basic anatomy and physiology is the foundation for diagnosing and managing GI disorders. When a patient presents with a GI complaint, you must think about which part of this intricate system might be affected. Is the problem in the upper tract, like the esophagus or stomach, or is it lower down in the intestines? Could an accessory organ like the liver or gallbladder be the source of the trouble? This systematic approach, grounded in a solid knowledge of how the GI system is supposed to work, will guide your clinical decision-making and ensure you are well prepared for any GI-related questions on your FNP exam. Gastroesophageal reflux disease, or GERD, is one of the most common conditions you will manage in primary care. It occurs when stomach acid frequently flows back into the tube connecting your mouth and stomach, the esophagus. This backwash, or acid reflux, can irritate the lining of your esophagus. The classic symptom is heartburn, a burning sensation in the chest, which often occurs after eating and may be worse at night. Other symptoms can include media group, patient experiencing regurgitation, person having difficulty swallowing, dysphagia, I distribute equally, regurgitation of food or sour liquid, difficulty swallowing, also called dysphagia, or the sensation of a lump in the throat. A key physical exam finding is often the absence of significant findings, though epigastric tenderness may be present. The first-line treatment for GERD typically involves lifestyle modifications combined with medication. You should advise patients to avoid trigger foods like media group, display of caffeine, alcohol, chocolate, and fatty foods on table. Close-up of trigger foods commonly causing GERD distribute equally, caffeine, alcohol, chocolate, and fatty foods. Suggesting they eat smaller, more frequent meals and avoid lying down for at least 3 hours after eating can also be very effective. For medication, H2 receptor antagonists like famotidine are a good starting point for mild, intermittent symptoms. For more persistent or moderate to severe symptoms, proton pump inhibitors, such as omeprazole or pantoprazole, are the gold standard. These are highly effective at reducing stomach acid production and allowing the esophagus to heal. Peptic ulcer disease is another important diagnosis. It involves open sores or ulcers that develop on the inside lining of the stomach. These are gastric ulcers, and the upper portion of the small intestine, or duodenal ulcers. The most common causes are media group, microscopic view of Helicobacter pylori bacteria, laboratory culture of H. pylori distribute equally, infection with the bacterium Helicobacter pylori, and long-term use of non-steroidal anti-inflammatory drugs like ibuprofen or naproxen. The hallmark symptom is a burning stomach pain. For duodenal ulcers, the pain is often relieved by eating, while for gastric ulcers, eating can make the pain worse. Physical exam may reveal epigastric tenderness to palpation. Management of peptic ulcer disease focuses on eradicating the cause and promoting ulcer healing. If Helicobacter pylori is present, the first-line treatment is triple therapy, which typically includes media group, proton pump inhibitor medication on table, doctor handing PPI prescription to patient at stock at distribute _equally, a proton pump inhibitor and 2 antibiotics, such as clarithromycin and amoxicillin for 14 days. If NSAID use is the cause, the offending agent must be discontinued if at all possible. In either case, a proton pump inhibitor is prescribed for 8 to 12 weeks to reduce acid and allow the ulcer to heal completely. It is crucial to educate patients on avoiding media group, NSAID medication crossed out, patient receiving handout on NSAID risks at stock at distribute _equally, NSAIDs, alcohol, and smoking, as these can all impede the healing process and increase the risk of complications like bleeding or perforation. Irritable bowel syndrome, or IBS, is a common functional gastrointestinal disorder. This means it is a problem with how the brain and gut work together. It is characterized by a group of symptoms that occur together, including repeated pain in your abdomen and changes in your bowel movements, which may be diarrhea, constipation, or a mix of both. On the exam, you need to know the Rome-4 criteria for diagnosis. Recurrent abdominal pain, on average, at least 1 day per week in the last 3 months, associated with 2 or more of the following: related to defecation, associated with a change in stool frequency, or associated with a change in stool form. The physical exam is typically normal. Since IBS is a functional disorder, treatment is aimed at symptom relief. There is no one-size-fits-all approach. For constipation predominant IBS, increasing dietary fiber and fluid intake is the first step, followed by osmotic laxatives like polyethylene glycol. For diarrhea predominant IBS, loperamide can be used as needed. Lifestyle management is key. This includes dietary changes like the low FODMAP diet, stress management techniques, and regular physical activity. Antispasmodics, such as dicyclomine, can help with abdominal cramping and pain. The goal is to improve the patient's quality of life by managing their most bothersome symptoms. Hepatitis, which means inflammation of the liver, is a condition you must be familiar with. It is most often caused by a virus. The most common types in the United States are hepatitis A, B, and C. Hepatitis A is typically an acute infection spread through the fecal-oral route. Hepatitis B and C can cause both acute and chronic infections and are spread through infected blood or body fluids. Symptoms of acute hepatitis can include fatigue, nausea, vomiting, abdominal pain, dark urine, and jaundice, that is, yellowing of the skin and eyes. On physical exam, you may find hepatomegaly, which is an enlarged liver, and right upper quadrant tenderness. First-line treatment and management depend on the type of hepatitis. For hepatitis A, treatment is supportive, as the infection is self-limiting. For acute hepatitis B, care is also supportive, but chronic hepatitis B may require antiviral medications to prevent long-term complications like cirrhosis and liver cancer. For hepatitis C, the goal is a cure. Direct-acting antiviral medications have revolutionized treatment, offering cure rates of over 95% with a course of oral therapy lasting 8 to 12 weeks. An essential part of your role is screening at-risk populations and ensuring vaccination for hepatitis A and B. As you prepare for your certification exam, let's review some high-yield clinical pearls. Remember that any patient over 50 presenting with new-onset GERD symptoms or any patient with alarm symptoms requires further investigation. Alarm symptoms include dysphagia, odynophagia, which is painful swallowing, weight loss, iron deficiency anemia, or a palpable mass. These are red flags for potential malignancy and warrant an endoscopy. This is a critical point for both patient safety and exam success. Never ignore these warning signs. They are a signal that something more serious than simple reflux may be occurring, and immediate referral is necessary. For peptic ulcer disease, remember the key difference in pain patterns. Pain from a duodenal ulcer often gets better with food, while pain from a gastric ulcer often gets worse with food. This classic distinction is a favorite topic for exam questions. Also, always consider Helicobacter pylori and NSAID use as the primary culprits. When treating Helicobacter pylori, be aware of regional antibiotic resistance patterns, which may influence your choice of therapy. Patient education is paramount. you must emphasize the importance of completing the full antibiotic course and discontinuing NSAIDs to prevent recurrence and serious complications like a perforated ulcer, which is a surgical emergency. When approaching a patient with suspected IBS, your main job is to rule out more serious organic diseases. A diagnosis of IBS is made based on symptom criteria after a thorough history and physical exam have excluded red flags like rectal bleeding, nocturnal diarrhea, or unintentional weight loss. For the exam, know the Rome 4 criteria inside and out. For hepatitis, focus on prevention and screening. Know the CDC screening recommendations for hepatitis B and C. For example, all adults should be screened for hepatitis C at least once in their lifetime. Understand the vaccine schedule for hepatitis A and B and identify which populations need them most. In conclusion, a strong command of the GI system is essential for any family nurse practitioner. Focus on the common diagnoses seen in primary care: GERD, peptic ulcer disease, IBS, and hepatitis. For your exam, you must be able to identify classic presentations, recognize alarm symptoms, and know the first-line treatments. Use a systematic approach, starting with the basics of anatomy and physiology. By mastering these core concepts and clinical pearls, you will not only be well prepared to answer any GI questions on your certification exam, but will also have the foundational knowledge to provide excellent care to your patients in clinical practice.